Dr. Asha Maita, so we shall have a 1 hour session. This is Ministry of Health Forum, and our topic today is towards a high quality Tanzania health system, role of human resource for health in improving patient experience of care. And we are going to have a discussion with directors and staff from the Ministry of Health focusing on this topic. Can someone find Dr. Steria? Dr. Steria, okay. We are missing one speaker, then we start. Okay, so maybe may you please come in the front seat so that people who are coming late, they can occupy the back seats. Please, may I disturb you? Can you please occupy the front seat? May I request you to occupy the front seat so that people who are coming late, they can occupy the back seats. It will be easy for them to attend. So as I said earlier, we will have a 1 hour session where this is Ministry of Health Forum. Our topic today is towards a high quality of Tanzania health system, the role of human resource for health in improving patients' experience of care. And the aim of this forum is to explore and emphasize the pivotal role of human resource for health, enhancing the quality of Tanzanian healthcare system, with a specific focus on improving patients' overall experience of care through discussions, insights, and strategies. And the forum will seek to address challenges, foster collaboration, and promote innovative approaches that contribute to the delivery of high quality of healthcare services and a positive patient experience within a Tanzanian healthcare system. So our speakers today are ready for discussion of this topic, and they shall have a few questions asked to them, and then after that we shall have discussion from the audience. So if you have any question concerning this topic, please just prepare it. You have your time to put it forward, and it will be answered by our distinguished speakers. So may I take this time first of all to introduce the speakers who are with us today. We have Dr. Tumaini Honga. This is a distinguished health promotion expert with a background in medicine and public health research. He has dedicated 7 years to preventive and promotive health practice and research in Tanzania. As Assistant Director for Health Promotion Section at the Ministry of Health, his extensive experience and contributions as a technical advisor in areas such as social behavior change, public health emergencies, risk communication, highlighting his vital role in shaping health policies and responses in the country. May we clap our head together for Tumaini Honga. Our next speaker, panelist is Dr. Caroline Damian. Dr. Caroline Damian is an accomplished medical specialist and Assistant Director for Public and Private Health Services at the Ministry of Health, combining strong leadership, problem-solving skills, and commitment to healthcare quality. With a background in obstetrics and gynecology and extensive administrative experience, she plays a crucial role in coordinating and ensuring the standards of healthcare services in Tanzania, while actively participating in professional association and research activities for further enhance expertise. May we clap our hands together for Dr. Caroline Damian. And our next speaker or panelist is Dr. Chris German. Dr. German is a dedicated medical doctor employed by the Ministry of Health in Tanzania for nearly a decade. Currently leads a supportive supervision unit at the Department of Health Quality Assurance. His pivotal role in developing and implementing digital supportive supervision system, THS, underscores his commitment in enhancing healthcare quality and his active involvement in various national quality assurance and improvement projects further solidifies his expertise in the field. May we clap together for Dr. Chris German. Thank you very much. Our next panelist is Asha Mahita. Dr. Asha Mahita is currently leading the medical tourism section in the Ministry of Health. He has an extensive experience in Dr. Asha Mahita is well experienced in public health specialist working in the health sector for 19 years in different leadership positions in local and central government in Tanzania. Currently, she is working in the Ministry of Health as the head of referral services abroad, as well as coordinating agenda for medical tourism in the Ministry of Health. He has strong leadership and health diplomatic skills and participated in different health forums outside and inside the country, enhancing public and private partnership approach in achieving quality of healthcare services. May we clap for Dr. Asha Mahita. And our last but not least panelist is Mr. Hussein Mavunde, who is very experienced in monitoring and evaluation and is the coordinator for Health Sector Resource Secretariat in the Department of Policy and Planning in the Ministry of Health. Can we have our hands for Mr. Hussein Mavunde? So we shall have 30 minutes discussion with my panelists. Then after that, we shall open the door for the audience to ask questions. Then after that, we shall conclude our session. Okay, thank you very much. May we have one mic? Okay, thank you very much. So our discussion will start with Dr. Caroline Damian. Dr. Caroline Damian, as an Assistant Director for Health Services at the Public and Private Health Facilities in the Ministry of Health. What is the status of quality of health services at the facility level, and what are the strategies to ensure that the quality of health care services is achieved at the facility level? Welcome, Dr. Caroline.
Okay, thank you very much. Good morning, ladies and gentlemen. Thank you, moderator, for the nice opening questions to me that to entail the status of health quality at the facility level. As he has introduced me that I'm an assistant director for the public and private health services at the Ministry of Health. So at the facility, when we are talking of quality of healthcare services, of course, it is a broader terminology, and if you define it in the service delivery aspect, generally we are actually looking at how much the service that we are delivering adhere to the available standards, the well-defined international and the national standards at our local context. And all in all, it actually needing to reflect on the effectiveness of the services that we are providing, and that means the evidence-based service that we are providing. But also we are looking at the safety aspect of it, that we should not harm on the service that we are delivering, or we should make sure that there's no any complications arising from the medication or the management that we are providing. In line with that, it has to be a people-centered. Our session today is actually looking at the patient experience or client experience on the service that we are delivering. So the people-centered or the services-centered, the individualization of the services is key and it's crucial. So to understand all this, there are some other well-defined components that include the timing or timely provision of the healthcare services, and that is improving on the turnaround time for each service point, and also avoiding the unnecessary delays or harmful delays to the service that you are providing. Also, it has to be equitable, and that means it has to take into consideration the variation of the nature of the client or the patient that we are attending. It has to be integrated as well as an efficient service that we are providing. So to measure all this, there are so many ways that we can measure. But of current, we know we have to measure the process and the supporting environment for the provision of the healthcare services. So we all know clearly that we have, for example, for the laboratory services, we have an accreditation processes of which entails how quality the laboratory, for the example, services are based on the accreditation process. But for the health services in general, which includes all the levels of services from the supportive and the key clinical services at the facility, then there are other methods of measuring. We know that we are currently doing the clinical audit, and the clinical audit actually meant to ensure or to oversee the process of service delivery from the patient when he comes in the facility to an exit point of the services, the actual process of service provision, the clinical aspect of it. We know we have the star rating mechanism and so many others which measures the quality. So you can use one or more than one or all together to measure the quality. So there's no single method that you can use to measure the quality of healthcare services to achieve all the dimensions that I've just mentioned. So what is there at the facility currently? With the clinical audit, the Ministry of Health had a clinical audit guideline which was signed and launched in 2020, and it actually started to be implemented in 2021, whereby we managed to conduct a clinical audit to all referral hospitals. In this, we actually started with the secondary and tertiary level, that the regional referral hospitals, the zonal, national, and the specialized hospitals, to understand or to assess the quality, the process of patient care. And that the clinical audit tool actually has three main parts where we use to assess. We are looking generally on the clinical case management, and that encompasses from the history taking of the patient, how do we clerk our patient, how do we examine, how do we come up with the diagnosis and the management process in relation to the clinical presentation of the patient. But also it is looking at the other issues like the laboratory, the investigations, the radiology, and the availability of healthy commodities. And the third part on it included the other cross-cutting issues and the patient-centered issues like the ethical consideration, the professionalism, the practices toward the patient, and the part 3 of the clinical audit actually entails about the patient-centered practices. So, is it last year, because I've just said that we have started with the referral level, is it last year the overall performance on all the three mentioned areas in the health facility, it was actually at the 50%. And normally, it is recommended at least to be more than 80%. We are all comfortable if you attend a facility where you are sure of the safety and the quality that you will end up when you present there. So the overall to the referral level, when we started, it was at 50. But when we did it the second the second round of assessment a year after, it had improved up to 60%. It is not really significant, but for us as the medical professionals, as the clinical service providers, we think it is significant because, you know, we are looking at the small, important clinical issues. So the progress is promising. However, the milestone could be little by little, but we are looking forward to improve as we move on because we have just started to understand the process of care. But on the other side, my colleagues will just talk on the accreditation processes of the facilities in general and the likes. So briefly, that is the status. And then now we are going to the primary health care levels. We have started with the referral to understand the situation, and the next step is just to go to the primary health care. We know over 80% of the patients we are attending at the facility are attending the primary health care facilities. So we think if we invest much on the primary health care, we'll have a big impact on the quality of services provided at the facility level. Thank you very much.
Good. Thank you very much, Dr. Caroline Damian. That was a piece of information from the Ministry of Health, that Department of Creative Services. Mr. Hussein Mavunde, you are coordinating Health Sector Resource Secretariat at the Department of Policy and Planning in the Ministry of Health, but we are facing human resource for health challenges. So do you have any strategy to address the shortage of, as we improve the quality of health service provision at the facility? Welcome.
Yeah, good morning, good morning of you. Yeah, yes, we have a shortage. You know, the requirement for the human resource for health, it depends on the number of the health facilities. The facilities we are having now, for the last year up to December 2022, we are 10,954 health facilities. They require a total of 348,923, but the available are 119,007, which is equal to 34%, and the shortage is 229,245, which is 60%. So you can see that our shortage is almost twice, because what we have only 34, and the shortage is 66. So there are other reasons for these shortages. The first reason is human resource for health attrition. Attrition includes all who are leaving or are leaving the system of health services, include those people who are retiring, death, some dismissals, and others. This part is human resource attrition. The second point which contributes to the shortage is the development of our infrastructure. We are building hospitals, health centers, and dispensers. These all need to have new health workers. So when we build facilities, it means also we have to look for the new health workers, but we're not doing that. The third point is increasing technologies. Some of the technologies need people who have been trained on how to utilize the technologies. So we are facing also a problem. We create shortages in this area also. And the last one, increase in service. You can find that there are big hospitals nowadays providing health services which were not being provided previously. So when introducing new services, also needing new trained staff. So those are the reasons for the shortages. But also we have strategies for addressing the shortage. The first is the ministry have created a 3 years recruitment plan. We call it accelerated recruitment plan, starting from 2024 up to 2026. This plan includes employment for all of those 3 years. We expect them to reduce the gap from 60% up to 44% when you reach the year 2026 through this accelerated plan. But also, we have another policy and also guideline we call task sharing. If we are strict not using this, we have to face many problems. For example, if you go to the dispensary in the village, you might find there's no clinical officer, no clinical assistant, but you have only a nurse and maybe a medical attendant. People are coming to get services, so the nurse will act like a clinical officer, prescribe, and also do his work as nurse. That's what we are calling task sharing. So by doing this, we are at least reducing the gap. So task sharing is the strategy. We have this policy and the guidance in place, and in fact we are doing that. The third point is we are nowadays using volunteers in our HIS facilities. We are accounting for that also as a one of the steps which are assisting to reduce the gap. The first point, we've trained our staff in different councils on utilizing WISIN. WISIN means workload indicator of staffing needs. WISIN actually produces the realistic demand of human resources. As you know, we are always using establishment which spells out that a dispensary should have 19 health staff. Health center, 39. That is for all the country. But it somehow is not realistic. If you go to the villages, you might find a dispensary. Around 5 hours in the morning, all the patients have been treated. If you go to other dispensaries, maybe in the nearby village, you may find there are a lot of patients, and the workers are working from the morning up to the evening. There is the same ECAMA establishment, which is whether the equal number of staff for all facilities, depending on their levels. But if you use WISIN, WISIN will calculate the requirement of human resource according to the workload the facility is facing. And also WISIN automatically suggests on how to redistribute staff from facility A to other facilities.
Thank you very much. Thank you very much, Mr. Hussein Mavunde. So can we go to Dr. Chris Gordon? The quality of care in Tanzania system has been well fitted into WHO framework of 2016, which groups into provision of services and experience of care, both supported by two pre-executive components. And so in your experience, what has been done in the Ministry of Health to improve patients' experience of care, and what are the strategies put forward to improve human resource for health knowledge, skills, and attitudes toward improving the quality of care? You're welcome, Dr. Kisgon.
Thank you, the moderator. Good morning, everybody. Okay, thank you very much. Before I try to respond to the question, maybe I want to put forward that, as the previous speakers have said, about the issue of having a quality health services and having a qualified and skilled healthcare provision. But in my presentation, as you have said, that in the quality of care framework of WHO, we have it has been divided into two major groups: the provision of the service and the experience of the care. So I'm going to talk more on the experience of care regarding the, in relation to health HRH. So in our services, I think we have a lot of construction, we have a lot of investment has been done in the health sector. But the issue of having a good experience of care has been a problem in most of the facilities, and that is the one which compromises the quality of service we are providing. So having a qualified and skilled healthcare provider, we expect to have the following in order to improve the experience of care. The first one is having the effective communication. The healthcare workers, we expect to have a good communication with the clients they serve. Also having a provision of care with dignity. That is one of the issues which we lack in most of our facilities. But also provision of care, emotional support for the facilities. So what has been done in our, by the Ministry of Health in order to improve the experience of care to our clients? First, we have developed several guidelines. So I'll mention a few of them for your information. So we have respectful and compassionate care, RCC guideline, which was developed in 2017. We have also national gender respectful care and mainstream integration for across RMNCH care, which was developed in 2019. We have client service charter, which was developed in 2018. Also, we have a guide for complaints, compliments, and suggestion management for health facilities, which was also developed in 2019. So all these guidelines were meant to improve the experience of care. So what, after development of these guidelines, several trainings for dissemination of these guidelines has been done at all levels of healthcare deliveries. So that is one, and most of the IPs have supported in the dissemination of these guidelines, which I have mentioned earlier. The other issue is about our professional councils have put forward the code of conduct to ensure that the health professions are providing care according to standards. So if there is any breach of conduct, so these healthcare providers were being called by their councils so that the appropriate measures are taken. So apart from these strategies, still we have challenges of increased complaints, waiting time for clients at the facilities have increased. So what are the strategies have been put forward to mitigate these issues? The first and foremost is inclusion of these client care and the customer care in our universities and mid-level cadres into their curriculums, so that when we are teaching young students, when they come to the healthcare, they have those competencies on client experience of care, including customer care services. Also, most of the facilities have started trainings of in-service in the issue of customer care. So most of the facilities, they have started teaching their health HRH on the issue of customer care in their facilities. Also, we are continuing to train and dissemination of those guidelines I have mentioned earlier. The other issue, as you have seen, I have mentioned a few, but as a ministry, we are planning to have a comprehensive customer care guideline. So I have mentioned like 4 guidelines which are, and we don't have a comprehensive guideline care. So that is one of the measures we want to have, so that we have a comprehensive customer care guidelines that will enhance our customer cares, our healthcare providers to have to work efficient. The other one is issue of building the capacity of managers at our facilities. So issue of having leadership and management skills to our managers at the facility is one of the most important issues that will ensure that we provide the care which meets the expectation of our clients. And finally, we request also our professional associations. I think in our medical field we have so many professional associations. So we request that these associations they put the agenda of client experience of care and issue of customer care as their main agenda in their meeting, so that we institute the culture of customer care and ensure that our clients receive a high quality care in services.
Thank you very much, Dr. Tisgon.
Thank you.
Thank you very much. Now we go to Dr. Asha Omari Mahita. You are the head of medical services abroad. And why the quality of medical care is considered as a crucial attribute to medical tourism. Welcome, Dr. Mahita.
Thank you so much. Good morning, everybody. Jamhuri ya Muungano wa Tanzania. My name is Dr. Asha Mahita, working at the Ministry of Health as the head of referral abroad and coordinating the agenda of medical tourism. As the question says, like, why quality of medical care is considered as an attribute of medical tourism. Today, the world has been very interconnected, whereby people travel from one destination to another destination to seek for the medical services. It can be international, it can be a domestic. So, and why these people travel from one point to another point to seek the medical attention? This is because in a certain point, there is improved of the quality of medical services. It's affordable. There is a confidentiality and easy to be accessed. As my fellows talk about the experience of patients on medical care, they talk about the customer care services. A person went to the hospital, seek a medical attention. He has to face this dimension of quality of care. We talk about the customer, we talk about the time, we talk about the technologies, we talk about the expertise, and we talk about the environment where the patients get the medical care services. But all in all, we talk about the branding of the services. But how are we going to brand that services? It has to be considered in ethical wise. So, no quality, no medical tourism. As we are expecting globally, by the year 2030, the economic gain through medical tourism, it will be about $360 billion. But that economic gain can't be achieved when there is no quality. That's why we say quality of care as something which is very complex and need to be achieved. Without that one, the medical tourism cannot be done. At the moment, at the Ministry of Health, we are promoting medical tourism in consequences all together with the improving the quality of care. We want people to be treated safely. We want the cure rates to be increased. We want the customer care services in all aspects to be achieved. Without the quality of care, it will be difficult as a nation to have issue of medical tourism. Even now, people they ask, you are promoting medical tourism. You think that, are you ready to do that? Are you sure the quality of care at the moment can motivate foreigners or even inside the country, people to come and get services at the facility? So, if you want to achieve, we need to improve the quality of care. Thank you so much.
Thank you very much, Dr. Asha Mahita. If you want to achieve medical tourism, we need to improve quality of care. Now, lastly, we come to Dr. Tumaini Haonga. The shift of health system focus from reactive curative care to more proactive health promotion and preventive care is a key component to improve community health system and hence to contribute achieving universal health coverage. So, depending on your experience, what are the key community health programmatic challenges, and can you tell us how you envision the community health system in the future of Tanzania for achieving universal health coverage? Welcome.
Thank you very much, moderator. and the floor. My name is Dr. Tumaini Haonga, Assistant Director for Health Promotion Services in the country. I concur with you that is currently it is a high time for us to consider shifting from the routine reactive curative services to proactive preventive and health promotive services. This is the case so that we can address the coming challenge in the area of emerging and re-emerging disease condition, non-communicable diseases, and other aspects of healthcare services delivery. So in that regard, the country is strengthening initiatives to implement the social behavior change communication initiatives, risk communication community engagement, community health programs, school health promotion services, as well as the forgotten but need to be raised health promotion initiative at service delivery points. So these key issues needs, among other factors, they also need strengthening the human resource for health at the community level, which is a key pillar in strengthening community health services to achieve universal health coverage. So we understand that for the long time, despite strong investment in the community health services, the program is still challenged by some critical challenges, which include the aspect of fragmentation, in which the challenge of coordination are affecting the program. You can find in an area you have a community health worker who is paid only to serve for one interventional area, while the same community health worker could serve more than one interventional area. So that is one. But also in the aspect of training. For instance, in the database, we currently have 20,487 community health workers who have received the trainings through different approaches. Some 3 days training, 2 weeks training, and in separate mode. But then these community health workers are also implementing services in a fragmented mode, not in an integrated approach. The other challenge is on the area of payment. So the modality of payment for a long time had not been standardized, and the ministry is currently working on this initiative in collaborating with community health stakeholders. The other issue is on the management information system, which are key to make readily availability of information, reporting, and also follow-up of programmatic issues in the community health. So having narrated those challenges, the government through Ministry of Health in collaboration with President Office, Regional Administration, Local Government, as well as community health development partners and implementing partners, is envisioning to have a new program which is an integrated and coordinated community health workers program. So this program addresses all the 5 challenges I have narrated. So under the program, on the aspect of selection of the community health workers, placement, we expect under this program, the placement starts at the rural hamlet level, which is the Kitongoji level for the rural areas and the mtaa level for the urban areas, where we need to place at least 1 community health worker, but we emphasize 2 for the aspect of considering gender and sexual reproductive health areas. And through the program also we have narrated different areas of focus, but these are cross-cutting through different health areas. They include, but not limited to, reproductive, maternal, child health, family planning, sexual reproductive health, nutrition, sanitation and hygiene, non-communicable disease, the communicable diseases, malaria, HIV, TB, the emerging and the re-emerging disease condition, of which we strengthen the aspect of community-based surveillance as well as risk communication to contribute to prevention and the control of these emerging and re-emerging disease condition. And this comes following the experience we have with these programs in the country and the contribution of the Community Health Initiative to control the public health emergencies. And also the other area is on the basics of social services promotion at the community level so that we can address the aspect of gender-based violence and the other issues in this area. So the other three issues to finish up on the aspect of training. Under this integrated and coordinated community health worker program, the training will be in an integrated approach delivered at the selected middle cadre health training institutions and is going to be a 3-month training, of which a 6-month training, of which 3 months caters for theory training and field consultation for the community health workers, but the rest of the 3 months will be the attachment to the respective village where the community health worker comes, but being supervised and followed up closely before being weaned up and graduating under the program. So in the deployment, thank you. In the deployment, we expect to provide them with monthly incentive and which is standardized. So upon their placement, the community health workers will be ready to provide a diverse of services, and they can be used by different partners and different local government authorities. In that regard, moderator, I pass my appreciation on behalf of the Ministry of Health and the PORALD to our development partners and implementing partners supporting the community health work, but also these transitions and the changes which are geared to improve efficiency of community health services to achieve universal health coverage following improvement of primary health care. Thank you very much.
Thank you very much. Thank you very much, Dr. Tumaini Aonga. Strengthening community health services to achieve universal health coverage. And it is just a coincidence that the director of the health services at the PORAG has just came in. The question was just well answered, and we shall have his contribution during the next sessions. So thank you very much, the panelists. That was a very great piece of information. Clap our hands together for the panelists. They really responded to the topic very well. So the door is open to the audience. Dr. Asteria Mpoto, can you please passing the mic to, if we have like 2 or 3 questions. So we have just a few minutes before the next session. So can you please be brief? If you can ask 1 question very briefly, then that will be great. Thank you very much. Welcome.
Thank you. I have 2 questions, very short. Can you confirm that we have 2,000 medical young doctors in the streets, but not in the health system? If that is so, we have bought CT scans, we have put MRI in regional hospitals. The only people who can use this equipment are medical doctors. And these equipments are all important for quality care. In addition, we have a lot of nurses well qualified in the streets. So can you people tell us, we have 7 years to universal health coverage. We have these people in the streets. Can they come into the system to help us accelerate this process? My second question is, I think you have all read minister's speech, this year's minister's speech. What is happening in Morogoro Hospital? in 2021 and 2022. In 2022, twice as much maternal mortality cases happened in Morogoro Hospital, Regional Referral Hospital. Actually, I have the figures, it was from 15 to 30. They have 2 specialists. And if you go into the figure, mothers are no longer going to Morogoro Regional Hospital. In fact, mothers overall, if you read in the speech, the figures are very clear. So what is happening in terms of quality of maternal care, maternal audit at regional hospital, having a rise in mortality, or about 5 hospitals at the regional level have twice as much mortality between 21 and 22.
Thank you very much. Thank you very much. Another question. So we shall have 3 questions, then they will be responded. Please be brief. Thank you.
Yes. Thank you very much, presenters, for the good presentation and discussion. Mine goes to the issue of quality and competencies. We understand that the Ministry of Health is a #1 consumer of a product from the universities, being mind nurses, doctors, and all other cadres. How do the ministry work with I understand that the training is on the Ministry of Education, but how do you work with other stakeholders to ensure that, as far as quality and competence is concerned, that the product coming from the universities, at least they have a good foundation? Because if you expect training when on the job training to have a good quality, it might be too late. Why don't we start at the foundation level? And we understand now, I don't know we have evidences, but by observation that the quality might be going down on the competence of graduates coming out from the universities.
Thank you very much. Thank you very much. Another question? Okay.
Thank you very much for the nice presentations. My question goes to Dr. Chris. I appreciate the efforts by the ministry, but also by the PRAG on ensuring that these new good guidelines, which are helping to improve the experience of care, are available in place and initiatives to train people are there. Have we ever thought that probably stress to some of these healthcare workers in terms of personal issues, family issues, or sometimes maybe unmotivated because of the low pay, which some people say may be affecting maybe their attitude when they are providing services? Are you thinking probably to do some counseling sessions or improving some of their welfares, which may also have a positive impact on the experience of care to patients? Thank you.
Thank you very much. Thank you very much. Then we have our last question. Can we have a mic to this lady? Welcome.
Thank you very much, moderator. So I really wanted to congratulate the panelists. I think it has been very, very informative. Pasha to you. We have learned a lot, and we really wanted to congratulate the ministry with the current initiative when improving the quality of care is concerned. I have very simple questions to Chris, and also probably Dr. Caroline can also help to respond. So do you have statistics in hand on how many regions, district council, or facilities have been trained on the customer care and also leadership and management component? Because as partners, our biggest role is to support the ministry initiative so that we can see where we can add our value in doing the same. And then 2, for Mavunde, I know HRH is one of the huge challenge to date. We have very, I could say, minimal strategy on retention mechanism. So what strategies are there in place at the ministry level to make sure that existing healthcare staff whom we have, who are doing a very good job, are retained? Thank you so much.
Thank you very much. Thank you very much. So we shall have a brief response from our panelists. Can we start with Dr. Caroline Damian?
Thank you very much. Mine are few, but I will respond to the quality in general. Of course, it was mentioned specifically for Morogoro Regional Referral Hospital. Of course, generally, the maternal mortality have reduced significantly, as we are all aware that yesterday's speech from the Minister of Health said it clearly. But for specific in Morogoro, I may not be able to explain that specific, but all what we are doing generally on the aspect of quality, we are looking at all the components I mentioned earlier on, the safety, and some other parameters. So it's very important as we are moving ahead on improving all those aspects to ensure that the safety of the patient is well improved, including the reduction of mortality and the morbidities associated with the services that we are providing. The other one is on the training, the data. Of course, my colleague here will say a little bit. But about the staff or professionals in the streets, we don't have only doctors. Actually, all the medical professionals around the streets without a formal government employment. But there are some efforts that the government is taking care of, including the employment by contract. My colleague has just said, Mavunde, maybe he will also explain a little bit. Thank you, that's all on my side.
Thank you very much. Dr. Chris Gon.
Okay, thank you, the moderator. I have two questions to respond. The first one is from, I don't remember the name, is about the issue of stress, overwhelmed staff, unmotivated, can lead to poor experience of care. Yes, I agree with you, because as Mr. Mavunde has said, we have a shortage of almost 66%, so they may lead to that. But the government, we have done many efforts to ensure that we mitigate these efforts so that we can have provide a good quality care services. As you have heard from the speeches from yesterday, we are employing a good number of staff every year, even this year, so that we increase the number of staff who will be providing the services. And also some motivations, we are paying the extra duties, overtimes, and all those to make sure that the staff are working in a good environment to provide the services that will meet the experience of our esteemed clients. So that is what but I agree with you, that may affect the provision of care. The other one from about the statistics. Yes, we have the statistics, but currently I cannot give, because I think we will communicate with you to give the real statistics. But the ministry, we have those statistics of how many staff have been trained in these those guidelines. But as of now, I cannot say, but we will communicate after this meeting so that you can get the statistics.
Thank you very much. Thank you very much. So can we brief, like 1 minute from Mr. Mavunde?
Yeah, welcome. Thank you. I have a question on the competence of graduates. The Ministry of Health and also Porage, we are receiving graduates from the training institutions. These graduates undergo training according to the curriculum which we have prepared. So we are sure that they've reached the standard which is required. That's one. The second issue is, after graduating, they are going also through the exams of their boards. For example, Tanzania Medical Boards, MCT, they have the exam for the medical doctors. Immediately after graduation, they go for the exams, and those ones who are failing, they must repeat again the exam until when they pass the exam. Also, it happened in the nursing council, they have the exams. But also, when they're in training, we make with Porage, we go to the supervision, including also the councils, technical council like NACTE. We are all together, we team up and go to the institutions to make supervision. So to our standards, that's what we are doing. And we expect all graduates are doing well, except now challenges come to their individual behaviors. Sometimes that's what is happening, but to our standards, we are fine. That's one. The second question,
Okay, thank you very much. Thank you very much.
The second question on the retention of health workers. I can say you cannot see the retention at the ministry level, but if you go down to the villages, you can find a different mechanism which are practiced by the local leaders to maintain their staff.
Thank you very much. Thank you very much. Let's capture our hand together for the panelists. We've completed our session. Another round of applause, please. Yeah, so thank you very much. Now, can you please have your seats? Thank you, the audience. Thank you very much for your patience, but also for your contribution and questions. That was very